Thank you very much. It's a real pleasure and an honour to be here, and I feel privileged to have heard from an incredible lineup of amazing women before me. And I've been quite moved by a lot of the presentations for a whole bunch of different reasons. One of them, I thought there's a question for me somewhere in all of this. Day one was all Annes and Alisons, but I'm a Marianne. So what does that mean? Am I on the in or am I on the out? And there's a question there for all of us about, you know, how we identify and where we come from. And I guess my statement is that there is no us and them. And as a Marianne, I am both one of the Annes and the Alisons, as well as the non-Annes and Alisons. In terms of my background, and there's an amazing background and wealth of diversity in the audience. I'm a medical doctor, and I've worked for 19 years now in and out of King's Cross and in drug and alcohol medicine and in public health. So I guess for me, as passionate as I am about my work, I need to acknowledge that it's my work. It has become part of my life, but I do get to go home at the end of the day, and I think it's important to acknowledge that that's not the same for everybody in the room. We're going to take a dive, and I'm going to tell you everything there is to know, not really, in 20 minutes about supervised injecting facilities, but I think that there's been a lot of comment about the social and the structural determinants of health, and I think that before we go to the pointy end of things, I, as a public health doctor, would like to acknowledge that we all could do more work reminding everybody that what makes a difference, as many people have said more eloquently than me, yes, is more treatment, and yes, is more drug and alcohol specific attention, but it's also about those first 3 years of life when we set up the trajectory of someone's later years, and if we can shift that, we can make an enormous difference down the track. In terms of the cards and the I commit to, I was reading a quote that the editor of The Lancet, Richard Horton, wrote just this month, and he's describing medicine and public health, and he's basically saying that they've completely failed to meet an emerging and growing challenge of insidious health problems in terms of hate, in terms of racism, in terms of xenophobia, and one could also add, obviously, in terms of drugs and drug-related harm. And he says that medicine and public health experts for too long have been preoccupied by the conventional causes of disease, and his final statement is that if our society is to achieve better health, we have to work out a better way to live together. And we have to embrace the full humanity of our neighbourhood. It's pretty good, isn't it? So I guess I commit to trying to make sure that my medical colleagues think more about the pointy end of things, but also about the structural determinants and about the lived experiences of the people in front of them, and that their voices are needed in the debate to try and change policy, because if you can make a little shift up here, you can make a big shift down there for the people that you see. So that's my I commit to. The only other intro remarks were just that I'm going to talk about something very, specific in terms of an intervention, but we always need to remember when we come to something, what is it that we're trying to fix? And I think there's been a lot of cross purposes of discussion really in terms of what's the problem and what are we trying to fix? Are we trying to fix organised crime? Are we trying to fix use? Are we trying to stop use? Are we trying to fix harm? If we're trying to stop harm or fix harm, what harm are we talking about? So to keep that at the back of our minds. So terminology is important, and as a young medical doctor, briefly being confused because the letters PR to me mean a digital examination with a gloved hand into somebody's bottom because it stands for per rectum, but obviously in the marketing world PR can mean different things. So So a DCR is a drug consumption room, or a supervised drug consumption room, like Alison said, and a SIF or a SIC is a supervised injecting facility. So basically, a drug consumption room is generally used in Europe, where most of the services are, and that's really the umbrella term, if you like. Supervised injecting facilities are drug consumption rooms, but they specify the route of administration. So at some level, they're often used interchangeably, but a supervised injecting facility is a type of drug consumption room. And what are they, as well as what they're not? So it is a legally sanctioned facility or place that enables or allows the personal consumption of previously obtained, previously purchased, illicit drugs. They don't actually always need to be illicit. You can come in there with prescription drugs, under the supervision of qualified personnel in a non-judgmental environment. And the key thing about that is that it enables in a legal or sanctioned manner, that it's supervised, and that it's non-judgmental. The key things that it's not a heroin prescription program. People come with pre-obtained, pre-purchased drugs, and instead of just giving the needles and telling them to go away, we provide them with a safer place and allow them to use. But we don't provide the drugs. It's not a heroin injecting room, because people can come with all sorts of drugs and use in that supervised environment in a non-judgmental manner. And it's not a drug testing service, because supervised injecting facilities the world over largely don't have access to the capacity to test the drugs that people are bringing in. So already there you can see this is not the whole solution. But I'll make an argument that for certain environments and certain local situations, it can be part of a solution to certain problems. In Australia, we've had a very proud history of harm reduction. We've become a little bit more shamefaced in recent years, but we were among the first countries to introduce needle syringe provision in the late 1980s, and that was basically because of the threat of HIV. I honestly wonder sometimes when I look at the current state of politics, and I wonder if we had all of those situations happening now and the threat of HIV, whether we'd actually get needle syringe and the provision of clean injecting equipment through our parliaments. We didn't have evidence then that it was going to work, and so you can imagine, and I'm sure many of us were around then, so many of the hard arguments have been won. And then in the 90s, we saw an increasing number of people dying of accidental heroin overdose in our country, that rose in 1999 to over 3 deaths a day. And we had a royal commission in New South Wales into the police force and the corruption that was associated with the drug trade amongst New South Wales police, and then, quote unquote, the picture that shocked and shamed us all. So this occurred in January of 1999. It's emblazoned on many of our memories for people that worked back then. We give our kids heroin injection kits instead of help. Now the health minister admits it's wrong. And a photo, allegedly, of a 12-year-old boy being assisted to inject by an older male. You look at that now, and that's a pretty shocking headline. And it could have led to all sorts of different things happening. Indeed, I worked on an outreach service at the time to a particularly poor and largely Indigenous neighbourhood. We went on a bus 3 days a week, and we were able to provide clean injecting equipment that was suspended for a period of time as a result of this headline. It also goes to show the importance of all of the preparatory work that is done in bringing people such that when you hit that crisis point, that tipping point, you maybe are more likely to go one way than the other. So the Premier at the time announced that if he was re-elected, he would hold a bipartisan drug summit. He was re-elected in May of that year, and the drug summit was held, and that was really an amazing time. Parliament was closed for 5 days, and it gave a chance for a long conversation. And I wasn't present at the summit, but I remember seeing some footage and hearing the stories of MPs that had their speeches ready to talk and ripping them up when they stood up to talk and saying, "I've actually really been profoundly changed by what I've heard and what I have learned, and now my speech to you at the end of 5 days is going to be very different to what I presumed I would be saying at the beginning of these 5 days. There was 172 resolutions. Only one of those related to supervised injecting facilities. And I'll come back to some of the wording. So basically I've put it up there. It's long and it's somewhat complicated, and that's not even the half of it. I've left out bits of it. But one of the important bits in that top line was that the government should not veto proposals from NGOs. And I think the longer I've been around, the more I've understood the importance of that as an approach for government. It also says that you need community support, and it also says that you need police support. There was another 2 years before the service where I now work was established, and you could probably do a whole presentation just about what happened in those 2 years. Initially, the Sisters of Charity through St Vincent's were going to run the service. There was a headline, a wonderful headline I remember at the time, that said, "The Vatican fears scandal more than death." And it was alleged that there was intervention from the Vatican down, allegedly through Cardinal George Pell, and the sisters were told that they would not be involved in that trial. And then there was a scramble to try and work out, well, who was going to run this trial, given that it had been recommended and the government was committed, at least at arm's length, to seeing it go through. And so the Uniting Church put up their hand. We opened in 2001, which is the same year that a couple of months before Portugal decriminalised drug use and invested in treatment in their country. We were the first supervised injecting facility outside of Europe, so we were the first in the English-speaking world. There was an utterly amazing amount of media and focus and attention, and it was really incredibly intense. And Ingrid Van Beek, who was the first director of the service, she's written a book about that period of time, and having spoken to her and watched from afar, it was incredibly difficult. And Fiona, when you spoke about R for resilience, I think she needed a lot of it back then. In terms of how it works, we have a specific amendment to the Drug Misuse and Trafficking Act, which is a state-based legislation about the possession and use of drugs and also permissive offences. So we had an amendment that allowed people to be in possession of a small quantity for personal use, and anyone that was engaged in a health service couldn't be offended. So the permissive offences were taken away as well. We can knowingly allow that to occur in our service. We are licensed, which means that the head of health and the head of police in our state grant Uniting a licence to operate the facility. So in that way, I actually not only answer through to the church, but actually answer to health and to police. So what does the service look like? You'll get an open tour to come if you're ever going to be in Sydney. I'd be delighted to show you through. We still run public tours. I know some of you have been through. I'm pretty sure when Ingrid set up the notion of public tours when we first opened, and before we opened, there was a sense that it's a really good opportunity for people to come and ask questions. I don't think she still thought, 16 and a half years later, we'd still be having 800-900 people through every year, but there you are. It's a pleasure to have people through. So we're set up in the business district and the main drag, if you like, of King's Cross, directly opposite from a train station, and most supervised injecting facilities are found near where there's, in port cities and near where the drug trade, because people buy and use and sell drugs all within a pretty limited area often. So it's a nondescript front door. You walk into a reception area that hopefully is friendly, and you see a non-judgmental smiling face. If it's your first time, you register with the service. We don't take your real name if you don't want to, and we don't check you for ID unless you're under the age of 18, because we're not allowed to let you in. And we get to know a little bit more about you, and you get to know a little bit more about us. You then walk through into a clinical setting, and this really does look like a health service, which of course is what it is. You are provided with the clean injecting equipment, which of course we know around our country we've been doing now for over 30 years, but by its very nature what we do is provide injecting equipment and then tell people to go away. We don't tell you to go away. We say wash your hands and take a seat at one of the booths. So people will sit down at a stainless steel booth. There's 8 booths, so a maximum of 16 people at any one time in stage 2. If people have attended the service together, they sit together, but otherwise we don't marry people up. If people are needing assistance and real-time advice about how to minimise the harm, we can do that. No staff is able to physically inject any client, but we can provide them with information and advice, given that the best efforts of society haven't stopped you at that point being an injecting drug user who has bought drugs and is intent on using. My job as a harm reduction health practitioner is to make sure that you suffer the least possible harm. If you have an overdose, we keep you safe, and then afterwards, just maybe, I've got an opportunity to have a conversation with you. If there is an overdose, we're able to intervene immediately and provide oxygen, so in that way we prevent deaths as well as injury. And we've got a small clinical room so that we can take people if they're needing ongoing treatment or monitoring. And then they go out into a much more relaxed environment after they've used, so that we've got the opportunity, they've got the opportunity to sit and hang around, we've got the opportunity to engage with them. It's not that every single person that comes through we say, right, let's talk to you about your use, you need to get on methadone, you need to go to resi rehab, you need to whatever. If you've ever obviously dealt with somebody who smokes and maybe you don't want them to smoke, it really is not particularly helpful every time you see them to It's about acknowledging where people are at and being person-centred and working out what it is that they want that day. And if they want nothing more than a conversation, a piece of fruit and a cup of tea, that's fine. We can provide them with clean injecting equipment at that stage, and there's a little private room out the back where we can talk to them about all sorts of other things, and we try and have, we've got on-site clinics now for a range of different things, for mental health, for housing, for liver clinics and fibroscans to get people on Hep C treatment, for dental issues. We don't have all that many people through while it operates because it's not a zoo, it's a health facility, but the times that we have, the overwhelming feedback has always been, gosh, it's not quite what I expected. And when I say to people, do you know what you were expecting? At some level, I realise what they say to me is, I kind of thought that it would be a bit more edgy. And I say, what do you mean about that? And the honest truth is, a bit like what Chloe said, you know, if you go to jail because you're a bad person, that means drug users are bad people. So therefore a service that sees exclusively drug users, there must be violence and there must be nastiness and there must be angst. It's just not the case. There's been many peer-reviewed scientific articles that have appeared in the literature to date. Firstly, we know that supervised injecting facilities / drug consumption rooms are very successful at engaging with a proportion of the population who use drugs who traditionally aren't finding their way to other health services, and in that way they can act as a fixed site outreach service. They can make contact earlier than might otherwise appear and therefore have more chance for a conversation earlier on in somebody's drug using trajectory with a hope of making a difference. They reduce the death and injury associated with drug overdose, and there is no question about that. Some work done in Sydney and also in Vancouver has shown a very local effect, so that the closer you are to the service, the more of the impact there is on reducing ambulance calls out to overdose and reducing deaths specifically. We know from some great work that's been done in Vancouver with a pre-existing cohort of people before the service opened that contact with the service means you are more likely to make it to a drug detoxification service, and through that more likely to make it to other addiction treatment services, including rehabilitation. We know that the risks for bloodborne viruses reduce amongst people who use the service and are taught and receptive to how to minimise their own harm and risks to themselves. We know that it improves the local community, and if you've lived and worked in an area where there's been lots of public drug use and people injecting in public and needles in the public, actually what you want is a supervised injecting facility, because that's the service that's going to take it off the streets and take it out of the public eye and take it into a health service. And also importantly, we know that they're cost effective. Perhaps most importantly on that slide is the relevant negatives. I think there was genuinely a concern early on amongst some people that this service was going to lead to masses of people injecting drugs in King's Cross and a flocking, a honeypot effect, if you like. Newsflash, King's Cross had the highest concentration of overdose deaths in the entire country before we opened. That's why we chose to locate ourselves where we are. The drug users were already there. The drug use was already happening. There's now been 5 reports by the Bureau of Crime Statistics and Research in our state that have consistently shown there's been no negative impact on crime. It's not a crime prevention technique directly. We're not a service that directly tries to reduce crime. Treatment services can do that. But the important thing is that we don't have an impact either way, and nor do we have any impact on the rates of people using in the broader community. There's also other benefits. We're obviously able to show real time because we ask people at that front desk, what are you using? We know what people are using over time, and there's actually been a real significant shift over the 16 years that we've been open in terms of what people were using, and we can relay that data to other people. So in that way we can be an early warning system. And you'll be understandable, those that have been watching North America, there's some real concern in Australia that the high potency opioids like fentanyl and carfentanil may make their way to our shores, and we're about to start a screening program, like a sentinel site screening or surveillance program, to see whether that's happening. It can be real-time, person-to-person health intervention. And I think it can help influence the broader debate about drugs. It helps to start a conversation. As I said, we show about 800 people through the service every year, and that's an opportunity to have a conversation with somebody who mightn't be your usual suspect. And it's not always just preaching to the converted. And it can potentially be a platform for advocacy. I said yesterday something about the importance of a church or a faith-based service running it. And I was speaking with Ian from the Salvation Army. The Salvation Army in Victoria, in the state to my south, actually wrote a submission to the Parliament, to their state Parliament, calling on a supervised injecting facility to be established in order to keep people alive, in order for them to then have the opportunity to get into treatment. And although I hadn't specifically thought about it when I wrote that, it's also a platform for advocacy for the individual. So we have a client or a consumer group that now runs and meets every 3 weeks. And because within those 4 walls, the use and possession of drugs is no longer a crime, they can actually sit down with police in their meeting and have a conversation with them. And I have a wonderful photo of the crime manager at the King's Cross Local Area Command and our group of consumers who'd met and had actually a pretty respectful conversation. And there's something about the fact that they're looking at the cop and saying, I'm a user and you know I'm a user because I'm here. But you can't do anything about it, and I have a legitimacy because I'm part of a group, and you were invited. We invited you to talk to our group. And there was an incredible sense of empowerment that came for those individuals. This is the graph, before we wind up, just of the different drugs that have been used at our service. So the top line, the black line, is the total number of visits per month. So you can see that that ranges from about 4,500 up to about, close to 8,000. And you can see from one side of the graph to the other, the colours of the lines change. So early on there was quite a bit of pink, that was cocaine. And then we had a period of 3 or 4 years where it was mostly the blue line, that's mostly heroin. Then we saw the emergence of this green line, which was prescription opiates, largely morphine and OxyContin. And after a period of time we saw them being actually more commonly injected than the heroin. Then we saw in April of 2014 an pretty impressive drop in that green line, and that was when the formulation of OxyContin changed to become tamper resistant, as it is in the United States. And you saw a bit of an increase in heroin at that time, so you saw the blue line go up. It didn't fully shift, so although when you pushed down on one you did see a pop-up in others, it wasn't equal in size. There has been an overall reduction. We're still seeing at the moment about 150 visits a day. We've supervised over 1 million injections. There's not been a single overdose death. There's been about 14,000 referrals into various treatment services housing and medical services, and about 2,000 occasions every year where we have specialised nursing care and support. The other thing actually about that graph is that you can also see towards the end there's a bit of a rise in the red line that's been going up over time. That's meth. So it's never flooded our streets, as you might believe when you read some of the headlines. It has become our second most commonly injected drug after heroin. It's always been opiates that have formed the majority of drugs injected at our service, and I don't think that's a coincidence. They're very good pain-relieving medications. And the people that we see, for a lot of different reasons, have a lot of pain that they may be self-medicating. But in all of that line of all of those numbers of the methamphetamine being injected, we've not had a single episode of violence associated with an incident that's led me to fill out a report, because it really does matter how you treat people. Very quick overview of what's going on in the rest of the world. There's about 100 services in 10 countries. Since we opened in 2001, 6 other countries established their first service. In Canada and Greece, they opened in 2003. Unfortunately, Greece later closed because of a range of both legal, political and economic reasons. Norway and Luxembourg opened up their first service in 2005, Denmark in 2011, and France just last year opened 2 services in Paris and Bordeaux, with another one planned for Strasbourg. In Canada, that traditionally has had 1 large service in the downtown east side and a smaller service there, 3 new services opened up in Montreal about a fortnight ago, and they've planned for another 10 across the country in response to the epidemic of overdose deaths. Ireland has passed legislation and are in the tender process to set up their first service in Dublin. Scotland is not going to be able to change law, but is looking at more a de facto way of being able to open up a service. Portugal, Slovenia, USA, a number of other countries are actively involved. And indeed, in my own country, in Melbourne, we've had an ongoing and sustained campaign to try and open up a service there. In fact, we've got the coroners who investigated an accidental overdose death in a particular area, and she basically made 2 recommendations to government. One was to establish a supervised injecting facility, and the other one is to make take-home naloxone, or a heroin antidote, an overdose antidote, far more available. I won't say a lot about this, but it's one of the areas where there's increasingly sophisticated debate about what are the best models of service delivery. Simply put, integrated services, generally speaking, I think are a much better model than standalone services and trying to retrofit clinics and services on after you've opened. Traditionally, we've always said that supervised injecting facilities work best, and they do, in concentrated areas of public drug use and high rates of drug overdose, and they do, and they don't necessarily need to be limited to that. The Dr. Peters Centre is a small service that operates in the downtown east side of Vancouver within an established clinic setting where they have HIV positive people who come for various day programs and do a whole range of different things. And oh, by the way, if they're there, if they just grab one of the nurses, they can pop into that room and inject. So I think we need to be clever and innovate about thinking other ways of models of service delivery. Obviously, the route of administration, increasingly as new services open, it's not just specific to injecting, and other routes of administration like inhalation and smoking are available. And then there's a debate about mobile or fixed site, which we can maybe talk about later. But basically, drug consumption rooms are local solutions to local problems. I think it's appropriate to see them potentially as an extension of the needle syringe service. They reduce death and injury, they reduce syringes in public. Importantly, they make contact with people who may not be making contact with other health services and other social services, and they can do that earlier than they might have had made contact without negative impacts. Last slide. In terms of lessons learnt, you really do need to have your police supportive, because if they're not, they can basically stop you being able to operate. They can pick up everybody and you won't get anyone through your door. So that's an absolute prerequisite. You need to get your community engaged, and you need to have them fighting alongside of you, your local residents and your local businesses. And we've always had the support of our local community, and it's increased since we opened. I said before, you need to be clear about what you're trying to fix. Is it overdose deaths? Make sure you've got good take-home naloxone programs and good access to opiate substitution therapy, which is an overdose prevention program in its own right. Is it bloodborne viruses? Make sure you've got good access to needle syringe programs. Reach out to faith-based groups. And as I was saying to Ian, it was a real pleasure for me to see the Salvation Army write such a positive submission to the Victorian Parliament asking for supervised injecting facilities to be opened. And as I said yesterday, as an atheist working for a faith-based organisation, I think that they can bring an amazing, potentially new voice to this debate. They have now got their synod, so their church body, to vote to start a campaign for removing criminal sanctions for the personal use and possession of drugs. I've heard Bob Carr a number of times speak about what was so clever in the way he worded, the government shall not veto. Governments do find it hard, for better or worse, to actively do things. Maybe we can ask them to not stop us doing things. It might make it easier for them, and it means that we've got to have our ducks lined up and be able to do it ourselves, which will push us to have our local community engaged. When it comes to it, keep your legislation simple. We have legislation that says a number of people are excluded from our service, including underage and pregnant women, which does not make good medical sense. We've got legislation that says there will only be one in the state, so Parliament has to meet with all of the public and media scrutiny that goes with that. And we have legislation that says as soon as our numbers fall below a different below a certain amount, the government is mandated to conduct an economic review, and even when they do that and find that it's positive, what happens the next time it goes to that same level again? Do they actually keep repeating the same review and spending more money to show the same thing? So keep the legislation simple. Design your evaluation well, be clear about what you're trying to fix and then how you measure it and what will look like good evidence. Be transparent and open, and acknowledge that people will disagree with me, and people will do that from a range of different reasons, and I will always invite anyone through the service and respond to anyone's questions, and hopefully, politely and respectfully be clear about where I disagree and why. Involve the affected community, and ultimately, which I guess we all know, be prepared for a long fight. It's a marathon, not a sprint. We operate as a trial for nearly 10 years. And 16 and a half years later, I'm still fighting to overturn some of those exclusions, even with the benefit of the College of Physicians and College of Obstetrics and Gynaecology. If a pregnant woman who is already an established drug user, who has already bought drugs and has found her way to the only safest place in the country in order to use those drugs, I believe very strongly as a doctor that I should not have to turn her away, because perhaps through coming out through the service, we can speak to her, we can keep her and the baby and the pregnancy safe, and maybe, just maybe, that's the opportunity to direct her into treatment and care. That's my email if anybody is interested in getting in contact, and this is a final quote from the Wood Royal Commission back in 1997, and it's always, I think, for a number of us resonated as perhaps the best way to remind ourselves what supervised injecting facilities are all about. Publicly funded programs operate to provide syringes and needles to injecting drug users, with the clear understanding that they will be used to administer prohibited drugs. In these circumstances, to shrink from providing safe and sanitary premises where they can inject more safely is indeed somewhat short-sighted. Thank you.